This is Dr. Seda from OSNT Educational Team, and I will be the moderator for today's session. As part of our regular OSNT teaching sessions, which take place every 2 weeks, today we present our presentation will focus about post-transplantation images, kidney transplantation. And as you know, kidney transplant workup is a multidisciplinary team approach. So we need our colleague from the radiology to start from the workup and also immediate, early, and long-term follow-up images. It's to play a crucial role in both routine surveillance and management of acute or chronic complication in relation to kidney transplant. So with great pleasure, today I would like to introduce our guest speaker for today, Dr. Yarab Al Bulushi. He's a consultant radiologist from Sultan Qaboos University Hospital, UMC. He's graduated from Sultan Qaboos University and he completed his fellowship radiology in McGill University in Canada. Also, he completed both the residency and fellowship in Canada, and he's a active fellow for Harvard BIDMC. I don't know what is the references of this, in abdominal and interventional image, as well as Stanford in cardiovascular and thoracic image. First of all, thank you, Dr. Yarab, to accept our invitation, and we are really delighted to have you with us today. So Dr. Yarab will discuss a post-transplant imaging. So please, you can start sharing your slides and we will keep the discussion part and the questions at the end of the presentation. Thank you.
Thank you very much, Dr. Sadia. Thank you everyone for the kind invitation. And I hope this will be a fruitful presentation. I'm very happy to present among colleagues in nephrology from Oman and outside Oman. Discussion will be about post-transplant imaging. And of course, it's a huge topic. If I'm teaching radiologists or radiology residents to require me hours, we'll go briefly over the commonest findings. And we're mainly focusing on post-transplant renal imaging, not pre-transplant workup. We'll go over the importance of renal transplantation, which of course you guys don't need to be preached about. And of course, we'll go over the radiologist role, renal transplant anatomy, and sorry?
Can
you hear me? All good?
Yes, continue.
Okay, sorry. So we'll go over the imaging modalities and then normal imaging findings along with complications, which are very important to you. So of course, as you know, like transplant of the kidneys improves patient's life expectancy, quality of life. It's much more cost effective for the healthcare system. And there is high demand for kidneys. I guess in Oman, I don't have the statistics, but from the US, where I trained, like they say that the number of transplanted kidneys in 2022 was less than 8% of those on the waiting list. And of course, in imaging, we help detect the complications and guide the appropriate treatment. And it's essential to differentiate between the post-operative complications because surgical or percutaneous interventions may be indicated in many cases. For example, if you have a pseudoaneurysm or if you're dealing with an infection. Of course, as you know, the renal transplant, so anatomically, like after they open up, usually they prefer the right iliac fossa region. After they open up the superficial structures, usually the transplant itself is placed in an extraperitoneal location, as you can see here. And you can have various types of renal artery and renal venous anastomosis. The commonest being an end-to-side anastomosis. Sometimes they would use a patch. Arterial patch in patients who have whose the transplant is coming from a deceased donor, and it has less likelihood of anastomotic stricture. But the commoner type is an interside anastomosis in the living donors, which is direct anastomosis, and the main transplant renal vein is directly anastomosed to the external iliac vein. So this external iliac artery, external iliac vein, and then you have the tunneled ureteroneocystostomy. And usually it inserts at the bladder dome. So by imaging, we always have to know what type of procedure was done in order to basically evaluate the kidney properly. We recently had, for example, at UMC, a case where two transplant renal arteries were like selectively or separately anastomosed. One was to external iliac artery, but the other one was to a more superficial artery. And that was very important knowledge for us when we were doing the post-transplant imaging. And of course, as you can see, so anatomically, we will evaluate the right iliac fossa for the renal graft. Sometimes we look at the atrophic or the native kidneys, but often our main evaluation are for the right iliac fossa, for the artery, for the vein, for the transplant ureter, and for presence or absence of a stent. On a CT, this is a corticomedullary phase CT, you will often sometimes be able to evaluate the kidney in different phases if you give contrast, but we try to avoid that, of course, in many cases, and you will be able to see the vein, the artery, and sometimes you can even do an MRA or CTA where you can map the vessels very well. And in normal anatomy, again, usually we prefer the right, but here is a case of where they transplant the kidney in the left iliac fossa, either from a failed right or due to anatomical constraints. And this is an en-bloc pediatric renal transplant where 2 kidneys were transplanted. We'll go over the role of each imaging modality, but basically ultrasound is our workhorse for most transplant kidneys. It's the first line. It's not nephrotoxic. We don't use contrast usually. It's low cost. It can evaluate both vascular and non-vascular complications. When we move to the CT or MR, usually it's a problem solving. So either to evaluate a complication that we detected on ultrasound, or to plan an intervention. For example, if we know that there is renal artery stenosis, we want to exactly know the level and the length of the stenotic stricture. Then we have problem-solving also techniques like fluoroscopy, for example, for urethral leak. We can use contrast enhanced ultrasound for segmental necrosis or infarct. We can use nuclear imaging for renal function. Normally, we will focus mostly on ultrasound, of course. And on ultrasound, we do both. You hear the B mode or B flow and color Doppler. So the B mode ultrasound is the regular grayscale. And on this one, we evaluate the kidney size, the corticomedullary differentiation, and we look for any peri-transplant collections, which again, immediately post-op, we expect some fluid. And then we look at the vascularity of the kidney. This is a color Doppler. This is power Doppler. Color Doppler usually have multiple colors. Power Doppler usually has just like one shade of color that has different intensity. And the basic idea is that we want to see vascularity up to the cortex. We want to see vascularity throughout the transplant, upper pole, interpolar region, lower pole. And that's how we evaluate the general vascularity. And then we have more advanced techniques. So we use basically the spectral Doppler and the color Doppler also to evaluate the renal artery, the main renal artery, for example, at the ostium, where it is implanted or where it's connecting anastomosing to the external iliac artery. We evaluate the flow velocity here, and this is a very important parameter that we have certain cutoffs for. We used to use like 200 centimeter per second, like in general, but of course that's more on the chronic stage. Early post-op, it can be higher a little bit. And we do the intrarenal arteries, which are like the arcuate almost level. And we check the resistive index, which is basically using the peak systolic velocity and the end diastolic velocity and calculating a resistive index. And we usually use a certain cutoff, which is 0.6 to 0.8 as the normal range. Whenever we're interrogating the renal arteries, you will always get this diagram where there is a grayscale image color on it. And then there is the spectral waveform. And then you will always see the numbers. We have peak systolic velocity, end diastolic velocity, and the resistive index, RI. So these are the important numbers you will be looking at. We always want in systole, both at the main renal artery and even at the intrarenal arteries, we want this sharp upstroke. Any blunting is not a good sign. Okay, so that's for the normal appearance. So how about the complications? So in order to look for complications, it's important to look at the timeline. And I know you guys are nephrologists. I don't need to teach you about any of the complications. You know all of them. But for us in imaging, it's helpful to categorize the complications in order to approach them appropriately. So we categorize, like you might have a complication which is related to perinephric collections. If we see something perinephric, it's important. The timeline, very important. The 4 main perinephric collections that we see are hematomas, which are usually very, very early post-op. Urinomas, which will occur within 2 weeks and more. Abscesses, which would take weeks to months to develop. and then lymphoceles, which would usually take weeks to months or even longer. The vascular complications also very important for us to know which day and what time post-op. Renal artery thrombosis, this is probably not a very good complication. It's the worst, and it occurs immediately, and often will be called immediately after the operation for this. Renal vein thrombosis can happen within the first 48 hours commonly, but can even stretch farther. Arteriovenous fistula usually post-biopsy and can happen anytime if you do the biopsy. Pseudoaneurysms, again, they can happen due to the surgical technique or from a biopsy, or you can get renal transplant artery stenosis, which we follow up and surveil the kidneys for often. And this would take 2 to 12 months to develop, sometimes earlier, sometimes later. Then we have the reteral complications, of course, the strictures and the renal calculi, which we can evaluate by imaging very well also. And then you have the allograft parenchymal complications. Those, I would say from now, like I can tell you that this will be the least specific imaging category that we can see. But it's important for us to know the context, whether it's an early, immediate, or intermediate presentation with renal dysfunction. Then we think about acute tubular injury, or something that is more chronic, or at least months within months, that is more allograft rejection, or a drug-related nephrotic cystoscopy. So the timeline here would be mixed, but the nephrologist would be guiding what is the likelihood of what we see on imaging. So the immediate post-operative complications, as I said, so we have the non-vascular and the vascular. Non-vascular will focus on the perinephric collections, and the vascular will focus on renal artery thrombosis, renal vein thrombosis, and renal artery stenosis. So how do these appear in imaging? So as we said, perinephric collections, 4 main types. They have that chronological order that I just showed. The imaging features overlap. So often it's either the timeline or the fluid sampling that will give the definitive diagnosis. So how do they look like? So the most important one I want you to know or like be familiar with is the hematoma. It's usually an early complication. It's usually a complex fluid collection. You can see the renal graft here. You can see a complex collection that is avascular. You don't see any vascularity inside. You see some vessels in the abdominal wall, some vessels in the adjacent fat, but not in the hematoma. On CT, it's a hyperdense collection, and it abuts the kidney. And this is a non-contrast CT, and you can see the density here is almost the same as muscle or more. And that is usually the clue to hematomas. On ultrasound, usually early post-transplant, again, you would commonly see this, like this is a patient 1 week post-transplant. You can see this tiny bit of fluid, hypoechoic. Usually no flow is detected here. We can see flow in the kidney. And again, so this is an indication of a hematoma. When do they cause more problems? When the hematoma starts exerting mass effect. And you can see in this patient on the Doppler, you see an area, there is no flow here. You see these dilated calyces. So you can have a compressive hematoma that would lead to hydronephrosis sometimes. So it's important for us to identify, and sometimes we follow it up more regularly on ultrasound to tell you whether it's regressing or progressing. The other perinephric collections we'll briefly go over is, for example, the urine leak or perinephric urinoma. So this is a CT at the delayed phase. Contrast is already being excreted at the calyces here, and you can actually see that there is contrast leaking. So instead of all going through the ureter, there is contrast leak through the renal cortex here. And actually, this was forming a perinephric urinoma. On non-contrast, on an ultrasound, this would appear just as a fluid collection, simple fluid. While an abscess, again, so the timeline is important here. This would be within 2-3 weeks. This would be more within like the first few months post-transplant. An abscess characteristic finding on imaging, again, it will be a complex fluid collection on all modalities, but on MRI or CT, you would see a rim of enhancement, a thick rim of enhancement, which wouldn't be seen with a simple hematoma or a non-infected urinoma, okay? And then this is the hematoma that we showed previously, but then this is the perinephric lymphocele. Lymphocele is often, again, just a fluid collection, smooth. Again, the timeline is important. We wouldn't see this early on. We would see it later on. It might develop over a period of months. It might have thin, tiny internal septations, as you can see over here. And again, so timeline would be important. Clinical presentation would be important. This patient would be febrile. This patient wouldn't be febrile. So all would be part of a greater workup for the patient. Now we move on to vascular complications. So these are high risk and time sensitive often. They occur in 3 to 15% of kidney graft recipients. So renal artery and renal vein thrombosis are probably the worst. And then you can have transplant artery stenosis, arteriovenous fistula, and pseudoaneurysms. These are the main categories. And mainly ultrasound is our workhorse for diagnosing all of these. That's why it's the best surveillance method. So renal artery thrombosis, it's serious, but it's very rare. Over the last 3 years in SQH, since I returned from fellowship, I've seen 2 cases. So not that common as the other diagnoses. It typically occurs early post-op. So patient just out of the operation, or even sometimes they call us for intra-op ultrasound, and we see that the artery is already thrombosed. There will be lack of perfusion if it's regional. It be like, for example, one segment of the artery or the kidney, or lack of flow in the whole artery. And if the patient ends up with a CT, or they shouldn't, you'll see no enhancement on the of the kidney. So basically, again, you'll see color Doppler outside the kidney, but you'll see no flow absolutely in the kidney. No arterial, no venous flow, because nothing is going in, so nothing comes out. And that's an easy diagnosis for us, but we don't want to see it. Then the renal vein thrombosis. So this is the like, again, another very rare complication, but it can cause a high percentage of graft failure. Up to 8% of graft failures are due to that. And it usually occurs in early post-operative period, like within 48 hours. So the difference here, you would start getting edematous, engorged kidney because the outflow is blocked. And you might lose corticomedullary differentiation. You might get perinephric fluid, often hematomas. You will get global hypoperfusion, but not absent perfusion. And you will get reversal of diastolic flow. So if you see this in our report, reversal of diastolic flow, okay, this is a red flag. Okay, this means you are dealing with absence of venous flow, probably. And this is an example. So compare this kidney to the one I showed you earlier. Compare this color or power Doppler to the one I showed you at the beginning. There is almost like very little flow, only mainly at like central aspects of the kidney. You can see here the spectral pattern. Can you see the diastolic here? Reversal flow. We shouldn't see in any end artery. We shouldn't see reversal of diastolic flow. We should always have some diastolic flow. So it should always be above the baseline. Okay. And lastly, when we did the Doppler for the renal vein, there was no flow, and there was this perinephric fluid, which is heterogeneous, some hypoechoic, some hyperechoic. So it was actually, there were hematomas around the kidney. So this is renal vein thrombosis. For renal artery stenosis, again, this is more of intermediate. So again, intermediate early, this is referring to time. It's the most common vascular complication. And usually we see it 2 to 12 months post-transplant. We have seen earlier cases, we have seen later cases. The main diagnostic criteria is ultrasound based. And we use this peak velocity of more than 300 usually as indicative of possible stenosis. So again, take the numbers with a grain of salt, as they say, I guess, because the numbers can vary. So if you tell me this is post-op day 0, day 1, I would be tolerant to some extent of high peak systolic velocity. And then I would start looking at these other parameters. I would look at spectral broadening, which I'll show you just an example later, or delayed upstroke, or basically the TARDIS parvus pattern, which I'll show you shortly. And then we can always, if there is a doubt on ultrasound, we can confirm by CTA, MRA, or just go to invasive angiography, which will be diagnostic and therapeutic. So here is an example, 6 months post-op. So this is the anastomotic site. When you interrogate it, the peak systolic velocity was exceeding 300. There is this aliasing. You know, you always hear us saying aliasing. Aliasing, usually you should see in Doppler blue and red. When you get like different colors and very high heterogeneity in the colors, we call that aliasing, because basically whatever we are sampling is beyond the speed of our detector. And then you can see actually the stenosis sometimes on B-flow mode of the ultrasound, and you will get this TARDIS parvus pattern. You see here, it almost looks like a venous flow. You don't have the arterial upstroke, and the upstroke is very slow. So that's the upstroke time is what we measure on these cases, and the time from the trough to the peak is what we measure. We don't want it to be exceeding 0.12 millisecond. And on invasive angiography, they catheterize, they can see the anastomosis and the anastomotic stricture. Sometimes if it's long-standing, you get post-stenotic dilation, but they can also do stenting or angioplasty and just fix the problem. And we have, unfortunately, cases where this has been done, specifically angioplasty, and then you get recurrence. So these patients would require close follow-up. Then last of the arterial or vascular complications, arteriovenous fistulas and pseudoaneurysms. They always or almost always occur post-biopsy. Unfortunately, they happen to both kidneys, native and transplant. There is often on the AVFs, there is direct communication between artery and vein. So you get very high velocity, low resistance waveform in a feeding artery with arterialized waveform in the fistulized vein. And the pseudoaneurysm, they can occur together. I'll show you a case. Is usually a contained vascular injury where like basically you have a big outpouching with a color browy or yin yang or like swirling of blood to and fro. The small ones, sometimes we leave to spontaneously resolve, but I guess I'll not talk about management because I'm not IR and I'm not a nephrologist. So for the post-biopsy complications, so this is a pseudoaneurysm. This actually, as you can see here, this area of flow, we don't expect that large vessel at the periphery of the kidney here. And this was a pseudoaneurysm, and you can see the flow pattern. It's very high velocity. You're getting almost 200 centimeter per second of flow within the kidney. That's usually never the case in a normal artery in the kidney. And then on a CT, this is a 3D CT scan, like with 3D recon, you can see the pseudoaneurysm. This is the feeding artery. This is the draining vein here. And this is early venous filling behind the artery. So angioplasty done. This is the pseudoaneurysm, the AV fistula. So the feeding vessel, the draining vein, as you can see it over here. And then they put a coil and everything was blocked. Okay. So that's for the vascular complications. Briefly again, for urethral complications, they are most commonly either stricture or stone, and sometimes you get extrinsic compression. They are often not like very immediate post-operative. Within the first 6 months, though, is more common. And you get sometimes mild hydronephrosis in most transplant kidneys. So don't be worried about that, especially if it's stable and there is no dysfunction and no clinical issues. Significant hydronephrosis usually would lead to calyceal dilation, renal pelvis dilation, and the ureter becoming much larger. And over time, it might produce cortical thinning, or clinically, you might see signs of obstructed system. This is a 3 weeks post-transplant. The calyceal system here is ballooned up, as you can see. So this is beyond the physiologic or the mild dilation that we see. And you can see that this area is, of course, important that you see that we put for you a color image on these areas. You don't want a radiologist to miss a pseudoaneurysm here and call it a dilated system as well. Okay. And then lastly, the last group of renal post-transplantation, transplant complications that I'll discuss today is the renal allograft parenchymal complications. These are like the acute tubular injury or acute tubular necrosis, cortical necrosis, drug-related nephrotoxicity. Unfortunately, imaging is not highly specific here. We primarily try to exclude the things that I showed you before when you send us a patient with this clinical concern. And many parenchymal complications will often require a biopsy. So we don't see much, unfortunately, in imaging, apart from, for example, what I'll show you here. So this is an early post-op ultrasound in a patient showing, again, you can see here, this is the peak in the intrarenal artery. We are right in the kidney right here. Sorry, the images are too small, probably. But basically, you see here the peak systolic velocity. We don't see any reversal of diastolic flow. These are just artifacts. But basically, there is absent diastolic flow. When you see that, the next thing you look at is the transplant renal vein, which I'm looking at it here. And there is flow. So it's not occluded. So it means I don't have a renal outflow issue. Inflow also, I can see actually the same problem in the main transplant renal artery. So high systolic velocity, no diastolic flow. And over here, this is another intrarenal artery showing the same issue. So it's not a segmental issue, it's a diffuse issue. Clinical context is very important here. This patient wasn't febrile. This patient was early post-op. Rejection is too early at this stage. So this was a case of ATN or presumed ATN. If you change the clinical context, you will have the same imaging finding. So if you tell me 4 months and suspected rejection, Okay, I'll tell you, maybe this is rejection. If you change the clinical context again and say a patient is presenting with fever, urine is growing, culture is positive, or maybe pyelonephritis is causing some derangement in the RIs. So unfortunately, those imaging findings you see here are not specific, but the clinical context will be very important here. I didn't want to take too much long of your time. I discussed with Dr. Sajid that we'll do it in 20 minutes. I took 23 minutes. So I didn't include much more complications. We could have discussed PTLD and other things, but I think these are the most important imaging findings or post-op complications we look for. So always just start with ultrasound, escalate as needed. As clinicians and as nephrologists, I guess I don't need to tell you what to do. You guys are experts and you often guide us, and we are happy to help you. Whenever you see our report, just recognize the red flags, and we'll often call when we see those red flags. And imaging will guide intervention, and of course, radiology can help you with the intervention such as biopsy, or for example, intervening with the renal artery stenosis, among other things. So thank you so much, and I hope this was useful, and happy to hear your questions.
Thank you, Dr. Yarab. Very focused.